We'll be discussing about 4 different classes of drugs: antiaggregants, fibrinolytics, thrombolytics, and hematopoietic agents. Now, here we'll begin with the first class of drugs, that is antiaggregants. So, as talking about this class of drug, antiaggregants, first of all, you need to understand what you mean by aggregation. Whose aggregation? Aggregation of platelets. Aggregation of platelets, it means what? Platelets, they begin to get deposited at one place and they aggregate. This aggregation of platelets, it is responsible for thrombosis, right? So whenever I give a class of antiaggregant, my aim is to prevent thrombosis. So first of all, we'd like to understand why thrombosis happens, right? So let us try to imagine a condition where there is a patient with blood vessel injury. Now, whenever there is blood vessel injury, this blood vessel injury, it releases factors which have different actions. So 4 factors are released. Number 1, releases factors which activates a glycoprotein called as glycoprotein 2B 3A. It releases a factor called as thromboxane A2 bicyclooxygenase, and it increases release of ADP, adenosine diphosphate, which stimulates a receptor called as P2Y12 receptor. And remember, these factors which are released now together these factors, they cause aggregation. So these factors, they're responsible for aggregation. Let us suppose this is my blood vessel and this was my site of injury. So on this site of injury, what will happen? All the platelets, they will come and begin to aggregate here. Platelets begin to aggregate. So this particular part that is happening here is called as aggregation. But remember, the aggregant of platelet is not the permanent thrombus. It is a weak thrombus. I need to make it strong. I need to stabilize this thrombus. How do I do that? For that, there is a 4th factor released. And this 4th factor which is released here, these are called as phospholipids. The 4th factor released are called as phospholipids, which activate our coagulation system. Right, an activation of coagulation system, what it does, all of you know, it forms thrombin, which converts fibrinogen into fibrin. Fibrinogen into fibrin, right? And what this fibrin does, this fibrin will make a mesh like this and it will stabilize the clot. So this is your permanent thrombus. So making a permanent thrombus, I need both platelets as well as coagulation system. In other words, I can simply say that the aggregation of platelets, it is just about placing the bricks together, right? But you cannot make a wall without cementing them. So fibrin acts like a cement. Apart from this, what thrombin does, thrombin here also stimulates. It also stimulates a receptor called as protease activated receptor, which is also responsible for aggregation. So your coagulation system, it promotes both aggregation as well as uh, uh, you know uh, the formation of thrombin. Now guys, here what is my aim? My aim is to produce anti-aggregant effect. So how can I produce that? For example, I can block GP2B3A by giving drugs like abciximab, so it is an anti-aggregant. I can block thromboxane A2, not the block of thromboxane A2, but I can decrease thromboxane A2 production by giving a drug called as aspirin. So aspirin does not block thromboxane A2, but decreases its synthesis. I can block ADP, or that is also known as P2Y12 receptor blocker, by drug like clopidogrel. I can block protease activated receptor by giving a drug called as Vorapaxar. So guys, overall, we have as of now four classes of drugs here acting as anti-aggregants, and we'll have a look at them one by one. Let us begin with the first class of drug, aspirin, the most important class of anti-aggregant. See, what is the mechanism of action? What is the mechanism of action? Aspirin, it acts by blocking cyclooxygenase 1. And by blocking cyclooxygenase 1, it decreases production of thromboxane A2. It decreases production of thromboxane A2. And this gives us anti-aggregant effect, as I have already discussed, right? Route of aspirin, guys. Route of aspirin, it is given by oral route. Uses. See, number one, it can be used in an acute attack of MI as well as unstable angina. So in an acute attack of MI or unstable angina, this is the first drug given in acute attack of MI or unstable angina, and here this we give chewable aspirin. Chewable aspirin is given, and remember here an important nursing implication is whenever you give a chewable aspirin, you ask the patient, don't swallow the tablet. Don't swallow the tablet. So I'll ask the patient not to swallow the tablet, right? So acute attack of MI, unstable angina, we give. These are also given for long-term prophylaxis. See, long-term prophylaxis, where I give it in patients with history of MI, patient who already had an attack of MI, patients with history of ischemic stroke, who already had an attack of ischemic stroke, not hemorrhagic stroke, right? These are also given sometimes in patients with diabetes mellitus and patients of angina, stable angina. So usually what happens is I'm giving a patient with history of MI so that he does not have another attack of MI, stroke so that he does not have another attack of stroke, diabetes mellitus so that neither he has MI or stroke, because diabetes can cause both, angina so that he does not have progression of angina and it does not develop MI in future, right? So these are the uses. And here for long-term prophylaxis, guys, oral tablets are given and these tablets are swallowed, right? These are not chewable tablets, these are swallowed. Now the dose of anti-aggregant dose that is to be given, it is 50 to 325 milligrams OD. So 50 milligrams to 325 milligrams once a day dosing is what is preferred. 50 to 325 milligrams once a day. So this is aspirin, guys, a very important drug. Now coming to side effect, Side effect is bleeding. Now remember, bleeding as a side effect can be seen not only with anti-aggregants, so all anti-aggregants, all anticoagulants, and fibrinolytics. So pretty much of all the drugs that we are going to discuss in this section, be it anti-aggregants, be it anticoagulants, be it fibrinolytics, all of them, all these drugs, they can cause bleeding. So there is an important nursing implication. And the nursing implication is number one, guys, you need to monitor the blood pressure and heart rate, right? Because a decrease in blood pressure or increase in heart rate, it would be a signal that the patient is going into hypotension due to bleeding. Second, teach the patient about different symptoms of bleeding. Teach the patient about different symptoms of bleeding. For example, blood in stool or vomit, right? So blood in stool means there can be blood in stool or there can be black color blood. This tells us that the patient is having symptoms of bleeding, right? And you'll ask the patient to immediately report back to you so that you can take care of that bleeding. So guys, this is one class of drug which is aspirin or cyclooxygenase inhibitor, right? Second class of drugs, guys, these are called as ADP inhibitors or P2Y12 receptor blockers. So these are called as ADP blockers or P2Y12 receptor blockers. And in this class, ADP blocker and P2Y12 receptor blocker, we have drugs which are of two classes. We have drugs which are irreversible and we have drugs which are reversible. Two classes of drugs. So irreversible drugs, the most important drug is clopidogrel. And clopidogrel, guys, it is used for long-term prophylaxis of MI or stroke. And for that, it can be used alone or with aspirin. So you can use it alone or with aspirin. There is no problem with that if dual anticoagulation is required. An important nursing implication, remember, it is contraindicated with omeprazole. So never ever use omeprazole with this drug because omeprazole, what it does, it decreases activation of clopidogrel. So omeprazole decreases activation of clopidogrel, the activity would be decreased. So it decreases activation of clopidogrel. So it's an important MCQ point, guys. Question can be asked. The second drug here, that is ticlopidine. Ticlopidine, it is a very toxic drug. It's a very toxic drug. And ticlopidine can cause side effects like GID side effects, nausea, vomiting, diarrhea. It can cause thrombocytopenic purpura, hemolytic uremic syndrome, TTP-HUS, nausea, vomiting, and diarrhea. And it can also cause agranulocytosis. Now, because of all of these complex of side effects, which are not very simple side effects, is the reason why these are not used. We do not prefer ticlopidine nowadays. Whereas the third drug here, prasugrel. See, I'll begin with the side effect of prasugrel. What prasugrel can do, prasugrel, it increases risk of intracranial bleed. And that is why you need to remember an important contraindication. It is contraindicated in patients of stroke and transient ischemic attack. This is this is an important nursing implication, right? So you have to ask the patient about history of stroke or transient ischemic attack. In that case, prasugrel should not be used. Which means what? Brain is gone. If brain is gone, I cannot use prasugrel in brain. Only organ left is heart, isn't it? So where do I use prasugrel? Heart. It is used for treatment of acute coronary syndrome. Acute coronary syndrome, like when the patient develops MI or unstable angina, this is called as acute coronary syndrome. I can use it, right? Whereas now coming to the reversible ones, guys. Reversible ones, we have a drug called as cangrelor. And cangrelor, remember, it has a very short half-life, 6 minutes, plus it is given by intravenous route. So cangrelor, it is used in an acute attack of MI for PCI, percutaneous intervention. That is, I do PCI to place what? Stent. So all of you must have heard about the patient was admitted, he was placed a stent, and that procedure of placing stent is called as PCI, percutaneous intervention. Now for that particular procedure, I need antiaggregant because you are introducing catheter into the blood vessel that can itself cause thrombosis. To prevent that, I can use cangrelor, right? Whereas ticagrelor, it is long acting and it can be given by oral route. Yes, it is also used in treatment of acute coronary syndrome. It is used in treatment of acute coronary syndrome, just like prasugrel is used. It is also used. So guys, these are the drugs. And remember, for your nursing exams, there are lots of drugs here. There are lots of drugs here, but for your nursing exam, the single most important drug is clopidogrel. Clopidogrel is the single most important class of drug here out of all the drugs that we have, because it is most commonly used in all the ADP inhibitor or P2Y12 receptor inhibitor. Right, now guys, coming to the third class of drug, these are called as glycoprotein 2B3A blockers. So glycoprotein 2B3A blockers, here we have drugs like abciximab, tirofiban, and eptifibatide. So abciximab, tirofiban, eptifibatide, these drugs, these are short-acting drugs and given by intravenous route, right? What is the use of these drugs? Abciximab, tirofiban, eptifibatide. So the use is in an acute attack of MI for PCI, percutaneous intervention. So this is a use that is similar to cangrelor, which I discussed, right? And out of these, see, the most important drug which will be asked in your exam is abciximab. So they'll ask you what is the use of abciximab, or which class of drug abciximab belongs to, anti-aggregant, how does it act, blocks GP2B3A, where it is used, acute attack of MI in PCI, right? And the last anti-aggregant, guys, the drug is called as Vorapaxar. And Vorapaxar, remember its side effect, it also increases risk of intracranial bleed. It also increases risk of intracranial bleed, Vorapaxa, and that is the reason why. That is the reason why it is also contraindicated in patients of stroke and transient ischemic attack. In patients of stroke and transient ischemic attack, Vorapaxar is contraindicated. So it is just similar to Prasugrel. Remember, we discussed the drug Prasugrel. It is just similar to Prasugrel, right? So use, however, is different. Vorapaxar, it is used for long-term prophylaxis of only MI, not stroke. It can be used along with aspirin or clopidogrel, right? Now, I have told you one common side effect of all of these drugs. All of them, they can cause bleeding. So you need to monitor blood pressure and heart rate and teach the patient about symptoms of bleeding, right? So that is something we have already discussed. So this is one class of drug, that is antiaggregants. Now let's have a look at fibrinolytics, which are also known as thrombolytics, right? So until now, I have told you that in the blood vessel, for thrombosis formation, there is first of all aggregation of platelets, isn't it? And then fibrin, it comes here and produces a mesh of network. And this is how your thrombus has been formed. Now, to break down this thrombus or to break down this fibrin, I have to break this fibrin to remove this mesh and dislodge this clot. Now, how fibrin is formed? That is, or how do I break fibrin? Now, remember, in your blood, there is something called as plasminogen, which is converted into plasmin with the help of a factor called as TPA. Guys, TPA is tissue plasminogen activator. TPA, it is called as tissue plasminogen activator. So tissue plasminogen activator converts plasminogen into plasmin, and what plasmin does, plasmin breaks fibrin, right? Plasmin breaks fibrin. So this is what physiologically happens in our body to maintain a balance. See, in our body will not try to produce too much of thrombus or too much of thrombolysis, so that there is neither thrombosis nor bleeding. So that is how our body controls. Now, fibrinolytics, what are the drugs we have here? We have drugs like streptokinase. Streptokinase, mechanism of action, what it does, it activates the tissue plasminogen activator, and basically it binds with plasminogen, and by binding to plasminogen, it uncovers the site of action for TPA. So in other words, I cannot say it stimulates, but it increases the TPA activity. And because of which, if TPA activity is increased, more plasmin means more breaking down of fibrin. Now, streptokinase, it is there are some drawbacks of streptokinase. Number one, it is a clot non-specific drug, which means what? It will break down fibrin. See, fibrin is present in the clot. Fibrin is also present in the blood. It is not non-specific, means it will break down fibrin present in the clot as well as which is present in the plasma, because of which it is called as clot non-specific, and that is why it has an increased risk of bleeding. It has a high risk of bleeding because of being clot non-specific drug, right? B, this drug it can cause hypersensitivity. So there is another drawback. Because why? At the end of the day, streptokinase, it is an enzyme which is given by IV route, ASE. It is an exogenous protein, and to exogenous proteins, all of you know how my body reacts, causes hypersensitivity. See, there is a high dose requirement. There is a high dose requirement, and why there is a high dose requirement? It is because, see, streptokinase is derived from which bacteria? Streptokinase, it is a product of bacteria Streptococcus. And imagine all of us at any given point of our lifetime, we have been infected with streptococcal infection. So, high dose requirement. The reason is because of anti-streptococcal antibodies. The reason is anti-streptococcal antibodies, which is present in all of us. They will neutralize it. So that is the reason why this drug is not preferred nowadays. This drug is not preferred, right? Streptokinase. Now the preferred drugs, these are called as recombinant TPA. Recombinant tissue plasminogen activator. Means in my lab, I have synthesized TPA, which is similar to this TPA. These are called as recombinant tissue plasminogen activator, where I have drugs like alteplase, reteplase, tenecteplase. So overall, remember, these are good drugs because these are clot specific. Means they will break down fibrin which is present in the clot, not in the blood. So that is the reason why they have a lesser risk of bleeding than streptokinase. So there is one benefit we have with these drugs. Now these drugs, guys, their route is also IV or intravenous. Recombinant TPA, they are given by intravenous route. Recombinant tissue plasminogen activator, their route is intravenous. And these are clot specific drugs. They decrease risk of bleeding than streptokinase. And uses of these drugs, guys, where they are used? Wherever a thrombus causes a disease. Where does a thrombus is responsible for disease? STEMI. So remember, they are not used. There is another type of MI, NSTEMI. They are not used in NSTEMI, only in STEMI. They can be used in ischemic stroke. They can be used in ischemic stroke, but remember, they are not used in hemorrhagic stroke. And they can also be used in patients with massive pulmonary embolism. So guys, STMI, ischemic stroke, massive pulmonary embolism, these are the different uses of these drugs, right? Now coming to side effect, I've already said, guys, these drugs will cause bleeding and nursing implication. I've already discussed above, right? Already I've discussed. Now, if they cause bleeding, then treatment, guys. Here the bleeding is massive. The patient might die. So the drug of choice for bleeding is a drug called as EACA, or EACA is epsilon amino caproic acid, EACA. What is the mechanism of action? Mechanism of action is, guys, it blocks plasminogen and blocks plasmin. It blocks plasminogen and blocks plasmin. So guys, drug of choice for EACA is drug of choice is EACA epsilon aminocaproic acid. And remember, it is again an important nursing implication because whenever you are giving thrombolysis, be ready with the antidote of thrombolytics, which happens to be epsilon aminocaproic acid. Right? Contraindication. Contraindication, remember, is very important. And contraindication, you can remember as brain contraindication. Right? These are not to be used in patients with brain trauma, patient with recent surgery, patients of aortic dissection, patients with intracranial hemorrhage history of. So if ever in his lifetime he had an episode of intracranial hemorrhage, we are not going to use this drug, right? And last is if the patient has non-compressive vascular punctures. If the patient has non-compressive vascular punctures. So brain, contraindication is brain, guys. You can remember as brain. So anywhere there can be increased risk of bleeding, it is not to be used. So it's an important nursing implication. Whenever the patient is to undergo thrombolysis, look at the history, ask the patient if he had any of these in the recent past, right? And then we'll not be using this drug. So guys, in this part of the lecture, this is what we are to discuss. Two classes of drugs we discuss, anti-aggregant and thrombolytics. And all these drugs, one common thing, remember, all of them, they can cause bleeding. So as a nurse, whenever a patient is on these classes of drugs, always keep an eye for bleeding as a side effect.